Good morning, everyone. Thank you so much for joining us. I'm Alice Casey with the Middlesex DA's office. DA Ryan should be joining us shortly, but I'm going to get us started today. We're really grateful to have some wonderful speakers today. We're going to start off with Sarah O'Brien and Charles Cremens from the ARC Behavioral Program. ARC Behavioral Health offers substance abuse disorder treatment at several different locations, particularly the Bedrock Recovery Center in Canton and its Spring Hill Recovery Center in Ashby. Both locations offer crisis stabilization services, and the Bedrock Recovery Center in Canton offers a primary mental health inpatient program. We're really grateful to have them. ARC is also dedicated to assisting in job protection, aftercare planning, and providing alumni services. So many, many thanks to Sarah and Charles. Why don't you get us started off?
Hello, everyone. Thank you for hosting us. And I work at ARC Behavioral Health as National Treatment Advocacy Representative. I do outreach, informing communities about the various programs we offer. And I myself, full disclosure, found long-term recovery through ARC's continuum of care. Sarah O'Brien was my guiding light throughout that process. And my background in recovery is alcoholism. And I found sobriety through AA and Bedrock Recovery Center, followed by Spring Hill Recovery Center. And Sarah was the person who helped me through that process. And I believe her story and experience within the world of behavioral health and recovery is more relevant to this task force. So I asked for her to speak today. And so I think that would lead the way. She's the national director here at ARC Behavioral Health and is instrumental in a lot of people's recoveries. I'm going to add our contact information into the chat if anyone wanted to reach out about taking a tour or setting up a Zoom meeting to ask further questions. And thank you for your time in advance.
Good morning, everyone. My name is Sarah O'Brien. Thank you, Charlie. Charlie has been instrumental in gaining relationships within the community, being a community presence and a resource for individuals that are struggling, providers, the workforce, different areas that have been looking for treatment options but have unable to find it or have had a tough time kind of navigating the whole system. And that's really what me and Charlie do on a daily basis is we work with a lot of community partners and just try to put out the resources that we have and also the resources that we can share, to help individuals that are seeking recovery that may not know where to start or may have a unique situation that they need, added support or a different type of path. I am also someone that's in long-term recovery from opiates. My journey started, as growing up in Massachusetts, that I was in and out of treatment for a long time. I utilized a lot of the Mass Health facilities throughout Massachusetts, and I was very, grateful to have those options when I needed them. I also utilized Boston Fire. My dad was a firefighter for a long time, so they're EAP, so they hold very near and dear to my heart, where they were able to assist me in finding treatment options. And now on the back end, I'm able to assist them with their members and their members' families. So I've developed a great relationship with them, and, it's really come full circle. I started at ARC Behavioral Health about 6 years ago, working in the admissions department and learning the process and procedures for someone getting into treatment and what that looked like. I'd never been on that side of the phone. I'd always been on the other side. So it was a really great, unique experience where I was able to learn, talk to individuals, see what they were struggling with, and then be able to assist them in finding what was next. From there, I started working with the community and the alumni. I enjoyed being out with the community, helping other women, and helping men as well, as they went along their journey, finding employment, going back to school, reuniting with their children, their families, gaining, a place back in society. And that was really, the start of my world into the community outreach. From there, I was able to develop relationships with police and fire, local police and fire, hospitals, unions, and other individuals that, sometimes can be overlooked and have a difficult time, seeking or finding resources due to their professions or their need for certain type of care, different lengths of stay or their ability, to go away for a good amount of time and receive the care they need to return to work. So what me and Charlie have done is started to reach out to different, task force, recovery centers, peer response, local police and fire, different, opportunities that we can just share the resources that we have. So if that someone seems that they have someone that would fit, the criteria for one of our locations, that we would love to be able to assist and help. So we do have 4 locations. Bedrock Recovery Center is located in Canton, Massachusetts. It's a 160 bed inpatient unit, 40 medical detox beds, 80 substance use residential beds, and 40 CCS beds. We were licensed by the Department of Mental Health last year to open a CCS unit, primary mental health, and it has been a game changer. It's been a place where people feel safe. They don't get to a place where a Section 12 is necessary. We are not inpatient psych. We are the step below inpatient psych. So we get a lot of referrals when they come out of a psych hold, or if they're not deemed appropriate. It is a great opportunity for individuals to get back on track, to get their medications on track, to be able to really get them on a better path before it gets too deep, and they require hospitalization. The individuals that we see range in all different types of mental health disorders, some anxiety, depression, schizophrenic, bipolar, external circumstances that may have occurred, loss of a job, loss of a family member, the inability to, complete ADLs. We've had individuals that have the dual on that unit as well. They may have been, had a substance use disorder, may currently have a substance use disorder, but the mental health is really primary to what they're dealing with. And if they don't get that mental health under wraps, then the substance use disorder is probably going to come to the surface. It's a way that individuals don't have to relapse in order to receive the help that they need, but they can go back into a safe residential unit for 14 to 28 days and get back on track with the help that they need. We have licensed nurse practitioners, psychiatry. We have medical staff 24 hours a day. We have clinicians, case management. We have behavioral health techs that all are there to assist in their need, similar to our detox and our SUD residential. The SUD detox and residential, similar to like any others, 7 to 10 days on a detox unit and up to 28 days on a residential unit for stabilization. We have a really great case management team that works with employers, that works with local law enforcement, probation, parole officers, that works to make sure that while the individual is receiving the help that they need, that everything on the outside is being taken care of, whether that is court dates, whether that is FMLA, short-term disability, whether that's, family law, any of those things that they worry about going into, they make sure that that's first and foremost. Our clinical team is all licensed. Our clinicians are wonderful at what they do. They're able to start the process of these individuals seeking treatment. They get them going on a route so that as they continue on, it's a short amount of stay, so they don't dig too deep. But as they start to dig through, the individual is ready for that next phase of care where they can really dig into what's happened, throughout the past. We have EMDR. And a lot of that's used for our veterans and our first responders. A lot of times we try to encourage people to obtain a little bit more sobriety, but if someone's been through it in the past, most likely it's a veteran or a first responder that has had some sort of contact with EMDR, then we do offer that as well. We work with the DOC for pet therapies. We work with outside health and wellness. We have health and wellness yoga, Pilates. We have pound instructors come in. Most of them are in recovery. They run meditations, they run sound baths. They do a lot of different things. Each unit is very unique and really serves a purpose for the individual that is seeking treatment. Our other facility that we have is Spring Hill Recovery Center. It's located in Ashby, Massachusetts. It's out by Fitchburg. It is a 28-day residential unit, but it's not a typical residential unit. It's a residential unit that's located on 70 acres of land spread across, a beautiful mountaintop. It's a facility that mimics a college campus, a ski lodge. It's a great place for individuals who are needing to be out in the fresh air, that feel as though that a residential type inpatient feel is just not what's right for them, that having the outside freedoms, that walking to groups, walking to the cafeteria, walking to the gym, going and playing volleyball, sitting by the fire, sitting by the woods, is something that they are, are better at, receiving that treatment as opposed to being inpatient. This is a up to 28-day program. It has all the same amenities, the clinicians, the case management, the behavioral health techs, the psychiatrists, the nurse practitioners, 24-hour medical care, has all of those things that Bedrock offers. It's just a different type of location. And that's really, the two main locations that we have in Massachusetts. We have a satellite outpatient location in Quincy from Spring Hill, which is commuter based, located off the bus line for individuals that may be returning to work, may be not able to live away from family or friends, or may be living in a local sober living that just want to continue on with their care, whether that be through an outpatient service every day or whether that be 3 days a week. It's a great opportunity for people to continue on once they leave residential, but return back to their lives, at a slower pace. So with that being said, each of our facilities holds very near and dear to my heart, seeing individuals like Charlie go through, regain his life, maintain sobriety, build up and not only just get sober, but recover, is why I continue to do what I do, and in full disclosure, my brother is a current patient, at one of my facilities, and the ability for him to know that he feels safe, that he can go there, that he can be treated with respect, that he can be treated with the utmost of what he deserves, going in at a broken point, is something that I really hold near and dear, similar to like the individuals that I serve, whether that be mothers, fathers, children, grandparents, whoever it is, when they come in to the facility, they deserve to be treated with respect. It's walking into a facility for any individual, is most definitely probably the worst day of their lives. But on the flip end could be the absolute best day of their lives, and that's what we aim to do. We aim to hopefully make that be that turning point where individuals come in, completely broken, hopeless, utterly, the inability to not, seek the help that they need because of the fear or the doubts or what's holding them back, but to be able to really, really, gain traction and recover. I just saw our question. We're actually working right now. Currently, I've been on a bunch of calls this morning. One of the units that we have one of the units that we have is empty at Bedrock. So we've been working with Mass Health contacts and with local facilities such as the Spectrums, the Washburns, Recovery Centers of America, to see how we can gain a quicker contract with Mass Health, see what that would look like for individuals coming in. That's kind of been the main drive actually within like the last couple of weeks, just due to the need for it. We've always tried to maintain and obtain like licensing for Mass Health. We did have an outpatient service that was in the process of getting licensed, but that facility has since closed. So we are working very diligently. Our investors and the individuals in the leadership program are really working. So I actually had a call this morning about that and about what that would look like in the turnaround time. Usually it's about 90 days, give or take. So that process is started. We're working with Tufts Mass Health at the moment, trying to obtain single case agreements to allow individuals to get the help before we have that contract. But yeah, so that's really all I have at the moment. If anyone has any questions, concerns, I know Charlie had put in our contact information, but we'd be happy, scheduling a tour, answering questions. I know it's a lot of information, and there's a 12.5 facilities probably within a 20-mile radius of where we are. And we're more so just wanting to be a resource that if you have an individual that may not even be a great fit, but you just need a recommendation, could be a child, could be someone who's elderly, could be someone who, suffers with a different type of disorder. We'd be happy to answer those questions and help, navigate that process, because it can be very, very difficult. And it can be extremely overwhelming for a lot of individuals, to find the right care for the people that are seeking it. So I'd like to thank you all for taking the time, listening to us and really just opening up, to another resource that we have. And like I said, please feel free to reach out for anything and everything. If you need, you know, me or Charlie, we're more than happy to help with anything that we can.
Thank you, Sarah, so much for all that information and for all that you're doing. Do we have any questions? You can just either raise your hand or just go ahead and speak up. Well, thank you very much, Sarah, and Charlie. Thank you for joining us.
Thank you.
Next, we're going to turn to
Thank you.
Thank you. Next, we're going to turn to a team that we have from Harvard Medical School. We're lucky to have Daniel Otero-Leon and Erin Stringfellow. We've actually heard from their team before in November, and they're here today to talk to us about what they've been up to in terms of analyzing data, particularly at a county level here in Massachusetts, to tell us about which substances have been involved in more spike days. They're here to talk about their results, discuss the implications with us, and talk to us about any future directions that we would like them to take in terms of the work that they're doing to address the needs of our task force. So we're really grateful to have them. I turn it over to you, Daniel and Erin. Thank you.
Thank you. Excuse me. I'm dealing with a cold, but I'm just going to introduce our team and our work, and then Daniel will be doing the main presentation. So yeah, my name is Erin. Daniel's here, and we also have Haru and Hannah with us. We're all researchers, dual affiliated with Harvard Medical School and also Mass General Hospital's Institute for Technology Assessment. We're a diverse group of researchers with many different types of expertise and experience. I and Haru are the primary substance use researchers on the team. Personally, I come to this work as someone whose family has been deeply impacted by substance addiction and mental illness. My background is in social work and public health, including a master's and a PhD. What all of us have in common is we use as much data as we can get our hands on to understand trends and patterns in drug overdoses. So this means qualitative data, interviews, just anecdotal conversations, quantitative data that might be collected from surveys or death certificates. Right now, we're funded by a CDC grant to better understand factors that lead people to have fatal and non-fatal overdoses involving cocaine and methamphetamine. However, we know in Massachusetts that often means that fentanyl is also present. For the project we're talking to you about today, it really got started with many conversations I've had over the years, not just here, but also when I lived in Missouri, with harm reduction providers, police, EMS, fire department folks who said that there are periods of calm with regards to overdoses, and then there'll suddenly be a spike, basically, where there are a lot of overdoses occurring within a couple of days or, you know, on a weekend or something like that. So it's worth pointing out that the overdoses that these are the ones they know about, and these are the ones where they were able to administer Narcan and hopefully the person survived. So just want to point that out because the data that we have access to is the death certificate data. So what I had put to the team was the question of, can we look back in the data and identify these spikes? Because I keep hearing this story, and maybe if we can find a pattern, something meaningful in the spikes, then we could actually prevent them or at least reduce their impact so not so many people are overdosing and dying. There are lots of discussions in research circles and elsewhere about how to reduce overdose deaths, but one thing I haven't heard really as much about is, you know, is there more bang for our buck, so to speak, if we could figure out what's going on with these spikes? If we're able to target these days, especially, could we save a lot more lives? So what Daniel's going to do is just discuss what we've been able to do so far with the data that we do have, with different methods that can be applied to it. But what we're especially also hoping for is your experiences and any suggestions you have that could actually make this useful for people who have to respond to overdoses. So with that, I will pass it over to Daniel.
Thank you so much, Sharon, for the introduction. And as she said, this presentation is more for receiving the feedback that you have for us and also discuss about the results. So please ask questions if you want to at any point. feel free either to write them in the chat or raise your hand and we can discuss the results. So let's begin quickly with, everybody can see the presentation without any problem? Yeah, okay, perfect. So just like a sample over here, I'm bringing the number of overdose deaths in Massachusetts for 2022. And you can clearly see over here that there are some days that you can consider spikes. And visually, you can identify them. But why are these spikes happening? And the idea not only is like, as Erin mentioned, if we're able to identify these spikes, but also can we see something around them? Like the patterns that we find is either because maybe a certain drug is the one that is making these spikes to happen during the year, or any other reason. So we try to answer this question, like, can we identify if some particular drugs are more involved in deaths during the spikes or not? And to do this, then we apply two models to answer this question. The first one is we need to identify spikes in a way, not only visually, but if we're able to do this correctly. And second, we need to identify which drugs are present in spikes versus typical days. As I mentioned before, there's days that are easily identifiable as spikes, but we need to do this a little bit better. So we apply an algorithm that helps us identify the spike patterns, and which could help prevent them in the future. This is an example from Massachusetts in general, after applying the model. And you can see that besides the one that I just circled before, now we have more spikes, more days are identified as spikes. But one thing that, of course, we thought about it and it was like, yes, nice that we can do this for the whole state, but is there any difference if we go within the counties? And we did this for Middlesex and for most of the counties in Massachusetts, and we saw that there's a difference. And for example, in Middlesex, 19% of the days are identified as spikes in 2022. And this, of course, varies substantially compared to the state. So if we want to do this analysis, we need to focus on what is happening in each of the counties. So after identifying the spikes, we started to analyze what is happening with the drugs and which ones are involved in the deaths. So over here, I'm presenting the distribution of deaths that involving with each drug involved in each of these deaths during a typical day and during a spike for the whole state of Massachusetts and for Middlesex. And there's a lot of information over here, but there's two things that we need to look into here that are quite interesting. The first one is that Massachusetts shows a similar percentage of deaths involving cocaine between typical days and spikes, like around 50% of the deaths involve cocaine, more or less around like 47, 48. And there's no difference between spike or typical day. While if you focus on Middlesex, you see that there is a difference. During typical days, it's around 37%, while on a spike, it's almost 50, a little bit more over 50%. And not only this happens for cocaine, you can see that there's also other differences in other drugs. For example, in prescription opioids, you see that there are more prescription opioids involved in deaths during typical days compared during spikes. So if we try to analyze what is happening for the whole state, is not the same as what is happening within each of the counties, in particular what is happening with Middlesex. And this is quite important, and yes, we can analyze this directly, but how can we do this systematically? And why, and we want to answer like, if which drugs, and identify which drugs do have a difference between typical days and spike days for each of the counties. So that's why we need a statistical model to do this. And we did this for most of the counties. And we used the data that Erin mentioned before, that is overdose fatalities from 2018 to 2022. Due to the amount of data that we have and due to the amount that, because we're analyzing what is happening between spikes and non-spike days, we include the following 6 counties in this result. And we did control for the county demographics using the latest census and also the overdose fatalities demographics that we had in our data. And which are the results? And here is where it would be amazing to hear your feedback and also see if you and also hear about what you think and if you've seen these same results in the field. And let's start with cocaine. This is for them for all the 6 counties, and you can see the following things. Here I'm presenting the adjusted odds ratio and a confidence interval for multiple different years from 2018 to 2022 for each of the counties. We see, for example, that Bristol in 2021, they had more deaths involving cocaine during spikes than in typical days. Hampden had also this behavior for 2021 and 2022. And Middlesex had this behavior for 2021, sorry. While if we look also from 2018 to 2020, we see something different. We see that Hampden, Suffolk, and Worcester had more deaths involving cocaine only during typical days. So we try to think like, what is this difference here? Like, what's happening between 2018 and 2020? And what changed after those years? What happened in 21 and 22? That some of the counties now present more deaths during spikes involving cocaine. And even although this in 21 and in 21, it was Bristol, Hampden, Middlesex, also 22, Hampden continued having this result. If we did the analysis for Massachusetts in general, they didn't show any difference for the whole state. So that's why it's so important to do this analysis per county. Besides that, it's quite interesting to check. And of course, this is something that we want to hear from you is, although for 2022, there's no difference between a typical day and spike statistically, on average, it seems that cocaine is more present in spikes, which, although it's not a statistical difference, may be something that could present a red flag for the future and something that maybe we need to consider going forward for if we start analyzing data for 23 or what's happening in 2024, if cocaine is also continuing appearing in spikes or not. And that's why we want to hear also what you think about it. Like, is this something that you see also happening or not? Besides that, if we go into prescription opioids, this is also something that is happening for multiple different counties, where we see that some of the prescription opioids also seem to have more present in spikes. But for example, for Middlesex, still they are more present in typical days, which is quite interesting to see why do we have this difference. Of course, this is meaning that what is happening between different counties and of course throughout the whole state. So in conclusion, it is essential to analyze data at a county level due to the heterogeneity presented in the state. Recently, cocaine seems to be more involved in deaths during spikes, and other drugs, in particular fentanyl, they have a high presence in overdose deaths overall, which that's why we don't see any difference between spikes and typical days, is because it's present overall. Thank you so much. So please, if you have any questions, feel free to ask.
Thank you. Questions, thoughts, comments?
Hi, I have a quick question. I think it would be interesting to if we could figure out how to show the trends in like significant drug busts or arrests that happened and comparing those to the spikes between the typical days. I'm just wondering if there would be a correlation between here in Massachusetts, national, big raids that have happened with fentanyl and stuff and how that impacts the spike. I don't know how we would gather that, but I think that would be interesting to see when we talk about accessibility of individuals getting access to these drugs. Is it a typical addiction, or is it that the area is just flooded for a certain amount of time because there's just so much in the area? I thought that would be interesting and part of, as you're thinking about data points and trying to figure out what's the difference between the two. I hope that makes sense, but that just popped in my head as something interesting.
Yeah, we've discussed that too. I think Daniel had found a little bit of data online, but that's probably going to be our answer to almost anything, is that if you know where such data might be, then we are happy to use it. So because there have been a couple of other studies that have definitely suggested a link between these things. So
Perhaps like partnerships with FBI or with local law enforcement and just looking at those trends and based on what charges come out,
yeah.
Might be a way to have a partnership that kind of looks at that.
Yeah, no, that's a good point. That sometimes, we try to see what we can find like easily available, and if not, then yeah, we have to start asking people directly. So
Anybody else? Thank you. This is very interesting data. Thank you.
can I ask a question of other people?
Oh, sure, of course.
To this point about data, if anyone knows like a good source of non-fatal overdose data that we could get, because what we've gotten from the state is not great. I don't know if there are any departments that are really good at tracking this who would be willing to work with us, because as I pointed out, what we hear about regarding spikes are from the people who have been asked to respond to overdoses. So those are the ones they know about. These might be the ones that people actually survive. So if there are any ideas for certain city or county departments or EMS companies, police, fire, whatever it might be, where we can also understand the non-fatal overdoses, that would be really helpful.
Pride Star, Trinity, and Lowell.
Okay.
John Kelly does an amazing job
Okay.
of tracking, and they're the biggest ambulance provider up in the Merrimack Valley now,
Okay.
because they've combined a few companies, and they do a great job of tracking it. They track time of day of the
Okay.
week. They do all of that. So
Great.
we can certainly send your info to John and have him reach out to you.
That would be terrific. Thank you. I'm seeing some comments as well about police departments. I'm sorry, CIMS is, what does that stand for?
That's the data that a lot of the police department, the critical incident system.
Oh, okay, critical. Okay,
And
thank you.
probably one of the chiefs who's done a really good job with that is Chief Berman in Wayland.
Okay.
He is a nurse as well as police chief, so he
Okay.
did a lot of work kind of figuring out the fields and doing all of that.
Okay, great. Thank you. Thank you.
Okay. Yeah, and there's also some information from BFAS about the harm reduction data in the chat.
Yeah. Thank you.
Of course. Thank you. All right. Good morning, everybody. I was, as I hope Alice explained, tied up at something else, but I think what we'll do is I'm going to turn to our last provider, and then I'll do my piece at the end. And then there are a couple of people I'm going to call on to talk about some separate issues. So we'll do that at the end. It really is my pleasure, and I know she is helping out one of her colleagues, the director who couldn't be here this morning, to have with us the deputy director of the Department of Public Health. Sarah Ruiz. And Sarah, I know you got sort of pressed in at last minute, so I'm really happy to have you here.
Great to be here.
And we look forward to hearing the information.
Thank you, DA Ryan, and it's great to be here. And you gave me a promotion. I'm the Deputy Director of BSAS, not all of DPH, which would,
Well, you should be.
yeah, thank you. Deputy Director for Strategy and Community Health at BSAS, and many of your names are familiar here, so it's great to see some of you and to be here. And I'm joined by Andy McConey is our Director for Community Health and Equity at BSAS. We're both the residents of Middlesex County, so it's great to be here. And unfortunately, our as DA Ryan said, our Bureau Director, Deirdre Calvert, wasn't able to join. This topic is a topic I'm going to present quickly on our hospital funding that we've just rolled out and want you all to be aware of. And this is something I'm working on directly, so it's great to be here to talk about it. Let me see if I can quickly share some slides. I appreciated being here to hear the other presenters, so thank you. That was very interesting, and I appreciate the work of ARC Recovery and of the Harvard Medical School. It's interesting to hear, so it's great to be here. See if I can shrink. So I'm going to keep track of time. Okay, I'm here to, as I said, give you an update about our hospital-based substance use disorder services initiative, really just rolling out now that we're excited to share about. So we were interested in funding, really promoting further these two models in particular that we have experience with in Massachusetts. Really, as we see here, that both opioid and polysubstance use crisis appreciate sort of the look at multiple substances in the previous presentation. They've led hospitals really to innovate and develop both low barrier bridge clinics and addiction consult services. And so we have experience with ourselves through funding bridge clinics, hospital funding, as well as addiction consult services. They were promoted a lot through the Healing Community Study. So there was more and more addiction specialists really working on these models in Massachusetts. And we wanted to boost these models and really partner on funding them and on sustainability together with a group of hospitals. So this is the models we were interested in. The goals really are primarily related to increasing access to medications for addiction treatment, the access to buprenorphine bridge prescriptions. There are requirements in the state for emergency departments to make buprenorphine available. We wanted to infuse some funding and some expertise to make these medications more available on demand in a low barrier method. So we have one goal of really increasing access to buprenorphine through the bridge clinics and emergency departments, as well as access to methadone through what we call the 72-hour rule. As you know, I'm sure you all know that access to methadone is heavily regulated through our opiate and available through opiate treatment programs or methadone clinics, and otherwise difficult to access for opiate treatment. There is this rule that allows hospitals and licensed prescribers to provide daily doses for up to 72 hours. So while you make a connection to care, and that allows somebody, as we say, OTPs can then accept patients as direct admission. So it really reduces barriers to access, and this is one element that we want to promote with our hospital partners. So it's exciting to increase access to methadone. It's really, we're seeing in light of just the levels of opiate dependence and with fentanyl that methadone is often the preferred by patients, and as much as we can improve access, we want to do that. So we released a funding opportunity over a year ago now that for hospitals to respond for these models. As I said, the goal really to increase. I appreciated the ARC behavioral health folks talking about treating people with respect and dignity and opening the doors to care, and that was really one of our goals, to help hospitals treat substance use disorder more efficaciously and with more dignity, and with having specialists and peers, and having really addiction teams available to serve them. So that was our goal, as well as making connections to care in the community. So we put out this funding opportunity. We got a tremendous response. We really were surprised and delighted at the number of hospitals that were interested in doing this work and receiving this funding. And we initially didn't have the funding really for all the hospitals that applied. And so we were working together for a solution, and really that we're grateful that for the opioid recovery remediation fund that considered this as a priority area. I'm sure you're all familiar with our opioid settlement money in the state, that we have a statewide pot, like of the total funding, right? 60% comes to a state pot that is overseen by the Secretary of Health and Human Services and the ORF Council, and 40% of the total abatement funds coming, go directly to municipalities, right, and some counties. So from the statewide pot, this is one of the priorities that was selected for funding. So through that, we're able to fund really all the hospitals that came in. So it's very exciting to have this opportunity. And it does add another level of public accountability and importance to that it's coming from this source. There is a special meaning for these remediation funds, of course, just them being abatement for harm caused, for lives lost. Really, it's very meaningful, like this funding source in particular. So it adds another level of public accountability and meaning to this work. So we're grateful to the ORF Council for this being one of many, and I encourage you to look at the materials that are posted, because we have lots of slide decks on all the initiatives that are funded on the ORF Council, by the ORF Council, of which this hospital work is just one. So we're grateful. Because of that, we were able to fund all of these hospitals. And we have these codes here for whether it was addiction consult service or bridge clinic or both. You'll see we have statewide coverage, really large and small hospitals. I highlighted and underlined the ones in Middlesex County. And it's great. Some are multiple hospital systems, like Bay State is working mostly in Franklin Medical Center, but with Noble and Wing. So with together doing the addiction consult across hospitals. We have a couple of the Beth Israel Deaconess locations. Boston Medical Center, of course, being a leader in this work, and really will also be help convene and lead this work with us in the state. Brockton Hospital coming back from having had a fire and really joining us in this work, which is exciting. Cambridge Health Alliance being, of course, the big one, with Everett, Cambridge, and Somerville locations, and Leahy and Burlington being another in Middlesex County. We have Lawrence, Lowell, and you'll see all these others. So it's been really a pleasure we've been meeting with each of them and getting them started, and the group of addiction specialists and hospitalists and psychiatrists that are joining us in this are just really great to work with, very committed to the work, the population, and just improving care in hospital settings, and increasing access to medication, and harm reduction, and recovery support, and whatever the patients need. So it's really been great to work with this group. So we are both for the opioid remediation, some accountability in terms of what are the indicators we're looking at. We are working together with these hospitals to increase access. We want to really track our key performance indicators. We're going to be collecting data together. A lot of the hospitals, of course, are very interested in, and our medical partners, and really looking at the outcomes together and tracking our indicators, really increasing the number of patients that are screened, and the care they provide, and connections in the community, and by gender, race, and ethnicity. We have absolutely an equity lens and interest in this work, and monitoring how people are cared in the hospital, making sure there's equity in the care and referrals that are given. There's a layer of interest related to pregnant postpartum women that often are sometimes seen in the emergency department, that it's an opportunity for us to improve care, but with an equity lens. And so we will be tracking these performance indicators and making them public. I wanted to quickly, this is a whole nother topic that I don't want to spend a lot of time on, but we have a new community profile dashboard at BSAS, which we're really excited about. I heard earlier the reference to the quality of DPH data, but we do have on here, not including data related to non-fatal visits and overdoses, as well as lots of indicators. So this is just a little screen clipping on our community profile dashboard. You can select either by county or by city, town. So for this, I selected Middlesex County. They'll show the rates, and if in the actual dashboard, when you hover over, it gives more information. So I encourage you to peruse what's available on the dashboard. I point out in particular, I sort of clipped out some of these ER emergency incidents from 2023 in Middlesex County that we have. You'll be able to see more detail on each of these indicators, but showing the rates of opioid related ER visits in Middlesex County compared to the state, EMS incidents, stimulant related, but alcohol. And I shared this in particular to show the high numbers of alcohol related ER visits, and that we're aware of the burden really from alcohol as well, and just the need in the Commonwealth. So this funding is, and work with the hospitals, is all substances, inclusive of people there for alcohol use disorder. So it's important to us that there's been so much focus on opioids, and that's been important, but we really want from BSAS to encourage as much as possible, sort of an all substance perspective. And there's so much multiple use as well in terms of the need for alcohol related work. So that is part of our initiative. Wanted to also just point out that one of our partners, the Rise Foundation, just announced this week, so they are also making some awards related to hospital linkage to care partnerships. So they have 8 awards also statewide for local organizations to partner with hospitals and to improve linkage to care and really follow up in the community. This is something they saw as a need in their research, and so we've been just coordinating with them, and 2 of their 8 awards are in Middlesex County with Lowell and with Cambridge Health Alliance. So there's more information on their website, but that's another opportunity for a collaboration with our hospital work that we're excited about. So this is just my last little slide, lots of words here, but we wanted to express how this initiative is going to be multifaceted. We're going to have technical assistance and learning collaboratives among the hospitals to share expertise across domains, lots of data collection and evaluation work together, local coordination collaboration. So I know this is, want to highlight that in particular for the Opiate Task Force and other partners, that we want as much as possible for the hospitals involved to have those connections in the community, and as much support as they can get with referral and follow-up with the patients coming through. We are working closely with the Mass Hospital Association, as I mentioned, RISE. And we're also going to have an element of medical billing TA and planning for sustainability. We know that there are disparities in coverage for different medical conditions, right? So it's been challenging for this work to be sustained through billing. So there's commitment to work with the hospitals. We have a consultant going to work with us and with Mass Health on examining the available billing and how can we really boost the addiction-related work and billing with the hospitals, so that there can be improved funding, improved experience for patients. So that is my quick run through, and happy to take any questions.
I think there's a couple of questions.
Okay. Yeah, I couldn't see the
in the
chat,
chat.
but now I can. Yes.
Why wouldn't the hospitals be both ACS and BC?
Some just chose, it was their choice to apply for one or the other or both. So not all were really in a position to do a bridge clinic, I guess. So that was their choice option, I guess.
All right. Other people have questions, comments?
I have a quick question, and I might have missed this in the presentation, but I'm just wondering, with the amount of money that is coming through the different states, I think you had said at the beginning, there's a pot of money that goes to the hospitals and then municipalities get some of that funding. Do you know of any programs or collaboration that's happening with the schools? Because as we're seeing an increase in like vaping and other issues that young children are now getting affected by the opioids, I'm wondering if there are any direct funding or ways that awardees are geared towards schools and young adults, and especially if they're coming through the pediatrician or to the ER, what kind of programs going around that? Because there hasn't been much around vaping education within our schools, and our schools are overwhelmed with what's being presented with them. To them.
Yeah, the vaping is quite extensive, right? Related to the abatement funds, the municipalities certainly can work with their schools, right? And prevention is one of the allowable expenditures, and work with the schools for the municipal abatement funds. We encourage municipalities to get community input on the needs in their community, and that work is certainly would be a great option for municipal abatement awards. As far as the state, we do have prevention funding. We're looking to do more and better with our prevention awards. We have our work with the Office of Youth and Young Adults. That's also in the schools. So we have some. There is always the need for more. So I appreciate you raising that up. But the municipalities definitely could be supporting work at the schools.
All right.
It's also, the RISE Mosaic, I see that Andy McConey put in the chat. The RISE Mosaic initiative is a grant opportunity, another funding opportunity that is going through the RISE Foundation, that it's with opiate remediation funds, and to make it available to other applicants. We get a lot of interest, and of course related to funding from the opiate remediation fund pot, and that is a funding opportunity that I think it's largely community-based organizations can apply. I encourage you to check it out and sort of make, as far as who's appropriate for that, but that is an avenue to apply for funds that do come from the state opiate remediation pot. So that is a funding opportunity to look into. Great, it's great to be with all
Thank
of
you, Sarah.
Thank you for having us.
Thank you.
Thank you.
All right, so I will go back as we always do and start to talk a little bit about what we've seen in terms of the last month. And again, and I say this always, we recognize that even one life lost to an overdose is too many. What we particularly know is that if you think just very conservatively, that a loss of one person impacts 10 people. And we know it's probably much more than that. But for all of the work that everybody on this call is doing and the changes we are seeing, we are literally impacting hundreds of people. So for the time period from January of 2024 to June 14th, we experienced in our county 64 overdose deaths, opioid overdose deaths. In comparison, for that same time period last year, we were at 94. So that is a decline of just over 32%. So again, you think about that's 30 people, multiply that by 10, we know it's conservatively 300 people whose lives have been made better by the work that this task force is doing. What is very concerning is that for that same period, our number of opioid used individuals who died by suicide increased by a third. We went from 7 to 11. And remember, we are very conservative about that. That is a case where it is incredibly clear cut. There's a note, there's something. It was perhaps witnessed, whatever. There are others which in that we count as an opioid death, which might have been intentional, but we are very conservative in getting to that number. But the fact that we have continued, and those of you who are here all the time know I've been tracking that increase for months. So I really think that's another target area for us. I also want to take a moment to think about the fact as we come near the end of June that this was Pride Month. And it impacts this work because according to the American Addiction Center, individuals belonging to a sexual minority are more than twice as likely to abuse drugs when compared to heterosexual peers of similar ages, socioeconomic, controlling for all those other factors. And we know that members of the LGBTQ plus community face many more challenges than their heterosexual peers, such as discrimination, bullying, potential rejection by family or friends, and may turn to the use of opioids to cope in those situations. And as Antonia mentioned a little bit earlier, we are continuing to see some very concerning data about the use of opioids among our adolescents. And we'll put in the chat, in June, there was an opinion piece in the Boston Globe really highlighting that impact on young people. And a truly scary statistic contained in that was that nationally, about 22 high school students during 2022. So during 2022, on average, 22 high school students died from an opioid overdose every week. Just think about that. I mean, that's a class. You think about a class at high school that might be 18 to 22 kids, it is essentially losing a room full of kids to an overdose every single week in 2022. The Federal Substance Abuse and Mental Health Services Administration has now come out with a recommendation, something we have been making every effort to do, and that is that schools be stocking naloxone. And I've talked about this before. What we have seen here in Middlesex is that the schools that have accepted naloxone for us, they are using it. Sometimes for people in their community, and other times, and this is pretty interesting when we first started seeing this, other times because someone may be, for instance, driving in a car with somebody who's overdosing. They are a fair distance, and that could certainly happen in this county, from a hospital or a medical facility. They see a school, they think school nurse, and they pull into the driveway looking for help. So we have continued to offer to every school in our county, naloxone. Will offer the testing strips, we'll give them whatever they want. So if you want to, if you're in a position in your community to see if the school has taken advantage of that and they have not, we are happy to get that there. And the reality is, it is our hope that just like people get trained in CPR, that kids will get trained in naloxone. Even if you don't believe your child has a problem, isn't going to have a problem, they certainly can be in a place where somebody, whether a friend or a stranger, is experiencing an overdose. And having that package of naloxone in their backpack or pocket or whatever can make all of the difference. You know, and we are fortunate here in Middlesex County to have groups like the Drug Story Theater, which I know many of you are familiar with. I just had an opportunity to go to their latest work. And they're really engaging younger people in an effort to destigmatize the use of opioid reversing drugs like Narcan, educating people on the susceptibility of kids to the use and the probability that they might be in a place where somebody's experiencing an overdose. So that's really always been one of the targets of this task force, is to share those kinds of that information and be coming together. I also want to talk about an article, and I know Mary Beth Murphy's probably chomping at the bit, which we'll put out as well, an article that was recently published in the Lowell Sun about the emergence of a new drug that is being sold in vape stores. And this drug is Kratom. I'm not sure I'm saying that right. I can't hear you. Mary Beth's forgotten how to unmute herself. Well, she will. It's an herbal substance that can produce either opioid or a stimulant-like effect. There's a concern about this drug, and there's a concern about whether it should be regulated like many other products are. And the city of Lowell is beginning to explore whether or not they want to put some kind of regulation in place. So Mary Beth, you want to take a minute and talk to a little bit about that? Pam, is she stuck? You want to do it, Pam? You want to do it?
Oh, I got it. I got it.
It was
Hello.
pretty funny watching you be completely muted, I have to say.
I'm glad I could entertain you. Good morning. Thank you for this opportunity. I did present with the Board of Health in Lowell regarding Kratom. I work at the Megan House Foundation, and we provide residential treatment services for young ladies who struggle with co-occurring substance use disorders. And I would say a little ways up the street, one way is a school and the other way is a four-way stop. And they opened up 2 stores with flashing lights, balloons, the whole shebang, and selling Kratom. And it's pretty horrifying. We went in and there's wall to wall of this Kratom, which is a legal herb. However, it is also known as gas station heroin. So if taken in smaller doses, you could get a stimulant effect. However, if you take it in higher doses, you get an opioid sedative effect. And people often use it if they can't get any fentanyl or opioids, and it will help with it will calm down the withdrawals and so forth. When I did some research on it, when I saw the stores opened up, and a lot of high schools and middle schools are seeing this with the kids. And because it's legal and they're getting their hands on it and it's really impacting. So I do want to bring attention to it, and hopefully it will be banned is my goal, working with the Board of Health. So just to throw it out there for people to be aware of what's being sold at these vape stores. And it comes in gummies, and the gummies are 500 milligrams, and they come in flavors that definitely entice younger purchases, cotton candy, punch. So all these flavors that these younger individuals will want. So please, just to be aware of it, that it's out there, and people die from it, and it can be very, very addictive. So I sent over a fact sheet to Nancy, and if she can share it, but if you go on the website, there's tons of information, valuable information regarding it. So I just wanted to bring awareness to it so that people know that it's out there. and it's really damaging. So thank you for the opportunity, DA Ryan,
Of course,
to share this, and hopefully this fight will continue to get it banned.
of course. And as Antonia points out, a lot of times, yeah, even younger kids are getting it from their older siblings.
Mhm.
So that, even if the store is following the rules about who they're selling to, it's certainly not impossible that a younger kid under 18 is getting that. Kathy, did you have a question? Kathy Miles?
Yeah, yes, I do. So I agree with you. 1 life saved is terrific, and certainly 30 lives saved is even more terrific. Do we have any sense of whether the usage of drugs is going up? I know, like I said, I know everyone keeps talking about the deaths going down, and that's wonderful, but I'm hearing that I don't see that we're just saving lives, but we're not necessarily preventing the increase in usage. Do you know is there any site that will give that
I
statistic?
did see that article last week that said that a lot of the risky behavior they were seeing a decline among teenage kids in Boston. I
Oh.
don't know how big a sample that was, but overall.
So we
drug
don't keep,
use, drinking, unprotected sexual contact, they were seeing a decline in all of those things.
oh, that's awesome.
Yeah.
Yeah. Okay.
I would just say that this is something we try to find data for all the time on, and there's not good data at all about people's actual drug use. So just putting in a plug for that, if there's any resources to do that, because the data we do have is not very good.
Thank you.
Thanks. I also wanted to point out that Maureen Busby, who I don't see on the call, was in touch with me last week to know that Reading last week passed the nicotine generation free law, which was a big success for them. They've been working really hard on that. That is a law that says if you are born after whatever the right year is, you cannot buy nicotine products. And the idea is eventually that everybody in a town or community would become ineligible to buy it. So they've been, Karen, I see you nodding. Do you want to add?
No, yes. So with several towns have done it in our area now. We're really excited that it's been a battle. Maureen's done an incredible job getting people to do that, to come to all the meetings and everything. So I think there's like 5 or 6 communities now that have passed that law, which is wonderful.
Yeah. Yeah.
We're
right.
we're working with actually many boards of health right now on that particular effort. It's a wonderful decision out of the SJC, just absolutely spectacular decision out of the SJC on that.
That was a big step. It was a really big step. And I know there's been a huge amount of effort to get towns to pass it.
Wasn't easy.
Yeah. Yeah. And the hope, I think, is it will become like seatbelts. Like
Exactly.
for maybe many of us, when seatbelts first came out, it was like, well, I don't want to do that. And kids who are of an age where they just grew up with them, they don't think twice about it. And what an amazing thing it would be if we could do that to nicotine. All right. Anybody else have things they want to share, upcoming events, things they need help with, issues they'd like us to think about addressing? No? All right. I want to thank our presenters and thank you for putting up with our sort of turning the meeting around a little bit today. I am grateful for that. And please have a very safe and happy 4th, everybody. Take care. Bye-bye.
Thank you.